Hello and welcome everyone. Welcome to this special cross-pillar webinar hosted by the Robert Wood Johnson Foundation's 4 Action Programs, Systems for Actions, Policies for Actions, and Evidence for Action. The 4 Action Programs are national research program offices of the Robert Wood Johnson Foundation that share a mission of funding rigorous research that studies the impact of innovative programs and policies on overall health and well-being of communities across the country. Hafade Todos Hamzu, my name is Paige Castro Reyes, and I am the Deputy Director of Community Campus Partnerships for Health, also known as CCPH, a national nonprofit that seeks to promote health equity and social justice through community and institutional partnerships. I will be moderating today's webinar session titled Challenging the Status Quo, Shifting Power in Research Partnerships. Today, you will hear from researchers and their community partners funded by each of the 4 action programs about how they are challenging the norm, how they are letting community partners lead the research, and how they are authentically incorporating community partners' expertise and lived experience. A few housekeeping items before we get started today. Today's session will be recorded, and the organizers will send follow-up communication with the recording and slides. We will also reserve time at the end of today's webinar for Q&A. If any questions come up at any point during the webinar session, please locate the Q&A box at the bottom of your Zoom screen and enter your question. Since we will be hearing from 2 different teams today, please indicate which team your question is for so we can address the correct individuals to respond. A note on our Policies for Action team, which is based out of Asheville, North Carolina. There has been an extreme amount of damage caused by Hurricane Helene, including power outages, and we do not anticipate them being in attendance, and our thoughts are with them and their community. I will now hand it over to each of the panelists to introduce themselves and their projects, and then I will guide us through the conversation.
He's on mute.
Sorry. Thank you, Paige. And hello, everyone. My name is JY Kim, and I am so honored to be here today and share some of my experiences and lessons learned through this project. I'm an associate professor in the Department of Health Services, Research and Administration at the University of Nebraska Medical Center. I've been doing some cancer screening research to systematically design, implement, evaluate, and disseminate evidence-based screening programs with various multi-sector partners and collaborators. As myself being a first-generation immigrant to the US, I deeply care about health disparities and truly enjoy working with communities that are experiencing these health disparity issues to improve cancer prevention and health equity. So that is about me. And shall we also introduce about our project now, or do we want to wait?
Yeah, we will come back to you, JY, about your project. I'm just going to do a quick note about the Policies for Action panelists. Rob Thomas, who is the co-founder of Outspoken Undaunted Revolutionaries of Asheville, and Chasity Leake, who is a versatile healthcare professional based out of UNC Gilling School of Global Public Health. Our thoughts are with them and their communities at this time. We will be sharing more about their work from the organizers after this session, but we wanted to make a quick highlight about their partnership and just sending a note to their communities. And I'll next slide for Latrice and Thomas. Lise Humans is unable to join us as well today, who's the founder and CEO of Change in Motion. And so, yes, thank you so much. And Dr. Rollins, please.
Hello, everyone. Thank you all for this opportunity and for joining us. I am an assistant professor at Morehouse School of Medicine in our Community Health and Preventive Medicine Department, and also served as the principal investigator for our project with Systems for Action called Research for Understanding Systems around homelessness, particularly for Black fathers. And so honored to be here and share a little bit more about our partnership.
And my name is Thomas Cotton. I'm the founder and CEO of Redemption and Advancement Alliance, where our mission is to disrupt the cycles of incarceration. I am a part of this group because Black homelessness is a big part of those people who are transitioning out of prison. The same racial disparities that we can see in our prison system, we can also see in our homeless system. So there's a historical systemic issue here. So it overlaps into the work that we do with preventing people from incarceration.
Thank you all so much. Again, these are the Robert Wood Johnson funded research projects, and we will be sending out more information about each of their specific projects after the session and potentially in the chat. I am uncertain about that, but I think we are going to pass it over to the next slides for JY to talk more about their evidence for action program. Thank you.
Thank you. Well, this study stems from an alarming statistic to me. It's by American Cancer Society that African Americans have 20% higher colorectal cancer incidence and 40% higher colorectal cancer mortality compared to white Americans. And the main reasons for high colorectal cancer incidence and mortality for African Americans are structural barriers to accessing quality healthcare and timely screening, which could be attributed to, in large part, to historical and persistent structural racism in the United States. So in this study, we use a unique cross-sectoral partnership with Nebraska's Department of Motor Vehicles, aka DMV, known to be the most popular public service locations, but has been undervalued as a place for public health promotion. So we work with them to develop a community-based screening program for colorectal cancer. And our goal is to reduce racial disparities around African Americans, especially for those who do not have or have limited access to healthcare or preventive screening opportunities, using colorectal cancer as a test case. If you go to the next page, so our partnership involves DMV, Nonprofit Cancer Task Force Organization, healthcare organization, and community organizations. Specifically, how this partnership works is that we use DMV's service location and their database for on-site and off-site mailing recruitment to provide eligible people with home-based CRC screening kits. For example, we set up a health promotion booth at the DMV locations, and our trained community health workers greet people when they enter the door at the DMV and say, like, have you screened for your colon cancer? And then once they agreed to join the study and get their kit, then there's this prepaid envelope in the kit that they could send their sample to the lab. And the kit is returned to the lab. And our staff member and our partner, Colon Cancer Task Force team, test the sample and notify the results, followed by our health system partner, who provide the navigation services for individuals with positive test results. And in all of these efforts, our community advisory board provide ongoing support and feedback for all aspects of our study. If you go to the next slide, here is the picture of our health promotion booth at DMV location. So during the 6th month of our first wave data collection, we recruited more than 300 Black community members who are eligible for this cancer screening kit. And among them, about 25% reported that they have no primary care doctor or health insurance. And of all the kits distributed, we've got 37% of kits returned. And of those, 18 people found positive, which means that they require a follow-up colonoscopy for confirmed diagnosis and treatment. 6 people who went through the colonoscopy found polyps and successfully removed them and prevented cancer. So that is it about our project. And I just want to acknowledge my partners, including Nebraska DMV, our Douglas County Treasurer's Office, Nebraska Department of Health and Human Services, our Great Plains Colon Cancer Task Force, Charles Street Health Center, and my interdisciplinary academic team members. And lastly, not the least, community members and cancer survivors who showed generous support and invaluable feedback for our project.
That's amazing. Thank you, JY. I think we're gonna hand it back over to Dr. Rollins and Thomas to talk more about their project just a little bit before we jump into the questions. So maybe if we can go back to their intro slide.
Awesome. Thank you so much. So as I was stating earlier, we focused in on Black fathers who are experiencing homelessness here in Atlanta and really looking at some of the ways in which these systems could possibly work better together to address the housing crisis that a lot of these fathers were experiencing. If you all typically think of housing services or any social services, they're typically geared towards mothers with children and various families, but we don't really think about fathers that have children, and a lot of the shelters that are designed here in Atlanta and probably in your communities as well don't really have spaces for families and specifically for fathers that have children with them. We know that there are a higher population of men that are experiencing homelessness, and we do know that a high percentage of those men, particularly here in Atlanta, are African American, but there are very few resources specifically for this population. And so as Thomas started to talk about working with a collective called Fathers Matter ATL, this is a collective of leaders who have worked together to promote and support father engagement in Metro Atlanta. One of the issues that came up was this lack of housing and lack of housing programs and resources for fathers in need, whether this was emergency shelter, whether this was transitional shelter, whether it was long-term housing. We were running into a lot of barriers with referring fathers to access to those types of resources. And so that's why and how this project kind of came about, and really trying to understand with so many resources, at least appearingly, targeted towards homelessness and targeted towards housing insecurity and all of these things. Why is it that these fathers continue to fall through the cracks and folks are not aware of the issues? So our work was to work with medical care partners, public health and social service partners to coordinate an effort, a systematic response to fathers who are experiencing homelessness. So if they are coming in to receive services through the medical center or our clinics, if they're coming into the public health facilities or social services, wherever they're entering, making sure that we have a common way to communicate with each other and refer them to some of the housing programs and the coordinated entry system that's here in Georgia. And so our work was really understanding where some of those barriers are, understanding where the why was it taking so long, and why was it so hard for these fathers to be housed? So really having those conversations with the fathers as they were going through the process, as well as having conversations with our partners about the whole process from intake to being able to deliver services. And so learned a lot, and definitely a lot more work to do, because we know that, if we're not able to get these fathers housed, there's other consequences to that. There's consequences in terms of their jobs, consequences in terms of just having a safe and stable space for them to have their children, live and thrive. There's consequences in terms of their health, the physical and mental health tolls, safety. So there's a lot of things as it relates to health equity, and even the structural issues as it relates to serving men.
And so, as Dr. Rollins was saying, we wanted to assess the system and really begin to figure out what the strengths and the weaknesses or the common gaps that are between our health service partners, public health, social service partners, and medical partners. When we understand that homelessness is something that impacts the Black community a lot, and when we talk about homeless fathers, we can identify how homeless is as a whole, but homelessness is as a whole. But when it comes to homelessness for Black fathers, they're almost invisible. And so within this study that we were able to, the research we were able to do, the objective was, again, to find the strengths and weaknesses of the homeless response systems, improve those linkages for housing, health, and social services for fathers, and then really adapt a system which allows us to identify in real time homeless fathers by name list, and then also having resources that can meet these needs immediately. We set out to design a database that would bring the services together. We were able to find a database that allowed us to engage and refer to many different support systems. It's called Unite Us, and so that's throughout the country, but in Georgia, we focused on Georgia. And what we really started off with was one father who had a son who had a need, and a significant need. And we have 40 plus partners within Families Matter, Fathers Matter, ATL. And it was so difficult for us to find just emergency housing for this father. And as many resources and many people we tapped into to find support for this father, it just wasn't there. So, we see a need, meet a need. So we embarked on meeting the needs of emergency housing first, and then how can we then strengthen what we're doing to be able to meet long-term needs? So housing insecurities and challenges that fathers have are being met at the same level as other groups.
Thank you both so much. Really appreciate you giving that overview. And thank you, JY, as well. I think we have set a good stage for us to start going through these questions. Thank you so much, Sabina. Okay, so the first question, and as a reminder, we're gonna go through these 3 questions first, and then as time allows, we will go back to the Q&A box. So if you have any additional questions that come up, please put them in the Q&A box, and just note which team or the group that you want to address this to. So the first question for both of your partnerships is, how does your unique partnership promote health equity and or address structural racism experienced by BIPOC communities? And I know that you all, in your overview of your project, definitely hit at a couple of these very clear markers. But if there is additional things that you want to say about as it relates to this question, and especially the compilation of your partnerships, I feel like that is a really wonderful just examples for people to hear more about the how you built your team together to address these structural issues.
I can go first. So the first thing comes to my mind is I think the partnership enables increased accessibility. A lot of times people hear about cancer screening from their healthcare providers, But so that means that if they don't have health insurance or they don't have family doctor, they lose this opportunity. And when people saw our staff at the DMV, they look a little puzzled first. Am I in the right place for paying my bill or getting my titles? Because they didn't really expect to see us, the cancer screening booth at the DMV. But later during our participant interview, they were appreciated about this opportunity to getting to know about this. And so I think having this collaboration with our DMV and County Treasurer's Office really enables to reach out community members who may not afford their health insurance, who may not have a primary care doctor, or who may have a doctor but rarely sees their doctor because they don't have time to, take a day or half day off. So we see these individuals while they take care of their bills or licenses without the need to schedule an appointment at doctor's office. And this is what apparently seen in the studies that have shown that colon cancer screening rates were notably lower for individuals without a usual source of care or health insurance. Um, and besides that, I think the convenience of screening test itself could lower the structural barriers. Many people have this biased perception about colon cancer screening that it needs to be done at the hospital setting by scope. This is true for the colonoscopy case, but people often do not aware that there is this alternative way to test without going through all these cleans and preps, food restrictions, and sedations. We provide home testing kits with prepaid envelopes. So people bring the kits home, do the test, and send the sample to the lab. And the lab technician enters the results in the secure database, and our staff sends the notification letter to our participants. And this testing and notification system has been established by our nonprofit cancer task force partner that has over 15 years of experience of colon cancer prevention campaign. So we don't create a new system, we just partner with them and share their existing systems and know-hows. And also lastly, the partnership connects people to healthcare system. So we have our federally qualified community health center as a partner, and they provide this navigation services for our study participants. One, if they have normal screening results, but they don't have doctor to report. So we connect them to the doctor in the system. And two, if they have abnormal screening results, but they don't have doctor or health insurance, our navigator reaches out to them and to help them schedule colonoscopy and file an application for their financial support if they need. So I'm going to stop here for my
Thank
side
you,
of answer.
Yeah, Dr. Rollins and Thomas, please.
So as I mentioned earlier, we are really looking at housing as a health issue. We have one of our partners to say that housing is medicine, so making sure that we are addressing this issue, which was brought to us by a father and experienced by a lot of the father-serving organizations that we work with as a challenge. We really wanted to center that, their experiences, and look towards some solutions towards advancing health equity in this space of housing. Understanding that if you have safe and affordable housing, that also contributes to you reaching your optimal health outcomes, whether it's physical, mental, a number of different things that this contributes to. So working with these different systems, making sure that they're aware of each other, the medical care, public health, and social service systems, bringing them together, understanding what those common challenges they may be experiencing and trying to address the housing issue, because we did have medical care providers that were doing screeners and had various interventions to help with housing, but weren't directly connected to maybe the public health or social services. And so just trying to get people out of their silos, and also making sure that, again, those fathers that have this lived experience, they were in those conversations as well, to share and highlight some of the challenges that they were facing with encountering some of those systems and some of the policies and procedures. From a structural racism standpoint, as I mentioned, we're focusing in on Atlanta, but typically, nationally, African Americans make up about 13% of the population, but 40% of those who are experiencing homelessness. In Atlanta, we have about 40% of the population is African American, and then upwards of 90 to 95% experiencing homelessness. So it's like, we really want to make sure that we look into these systemic areas and these systemic barriers, particularly as it relates to men, because a lot of our social services and health systems aren't designed to really provide resources and services to them. So making sure that we lift up their unique challenges, their unique needs, and also, lift up various resources that can help them, was a good way that we were able to work together through this project.
And when we think about Black fatherhood, we understand the challenges that we have in this country when it comes to fatherhood and fathers in the home, and the challenges that just Black fathers face. So I'm not going to go too deep into that, but what I will say is that it's a multifaceted issue that's shaped by economic and challenges, disproportionate incarceration rates. And so there's a lot of different challenges that have to be overcome. When we're thinking about Black fatherhood, we're thinking about health equity and safety, and being able to address common concerns that we all may have if we're in these situations. We want to deal with the housing insecurities. We want to make sure that that there's a network of resources that they can go to and not get a runaround. There's a lot of times where people will go to find the resources. They need the help, they need the support, they're reaching out, but they get turned away, whether it's because all the resources are used up or they're not specifically for this group of people. But when we have a system that can provide economic and social support, it really helps with, it could help with affordable childcare, employment opportunities, financial support, which allows the family to stabilize and reduce poverty. It helps to really address a lot of the challenges that we've seen in this country for, centuries or decades. And so we don't even have to go back centuries, just the decades. And so we're looking at tailoring things when it comes to fathers who want to be back in their children's lives because they were just impacted. Reentry programs are highly important for that. And being able to take an individual who lived a certain life, recognizes they're wrong, wants to turn their life around and change, and get back into their children's lives. These fathers, and the ones that have never been justice impacted, all fathers need to have the resources that are available to them.
Thank you all. I want to uplift that both of your projects, of course, our Systems for Action team is based out of Morehouse School of Medicine, but also JY has a partnership with Charles Drew, which I think it's important to uplift those institutions that have been serving the communities that these projects are for. So I just also want to make note of that as well. Next question, please. So how does your partnership challenge traditional power dynamics in research? And that kind of comes along with my comment that I just said, but also would love to hear more specifically how your partnership as a team and also just the institutions and how you're maybe you navigate decision making, or there was a question on data ownership or on advisory and steering, where those pieces come into play in your partnership, and how your process is also challenging these systems that you are seeking to to dismantle within your work?
I think the cross-sector partnership really challenges this traditional power dynamics in research, where typically researchers have more power, and then study participants and community members are recipients of the research. But I think this partnership really provides more power and authority for our partners and community members. We developed our community advisory board, and our community advisory board, and I think this might be an answer to the first question about the community advisory board, but this is consisting of representative from each of our partners and community members and cancer survivors in the community. So it's about 15 people, and the board members meet quarterly and provide ongoing support and guidance for every aspects of the project, including the program design, preparation of the materials, implementation, evaluation, and dissemination. And to make a good balance of decision-making power and authority in our community member, in our group, we decided to have this meeting co-led by the two leaders, one from the academy and one from the community members. So, I think the advantages of working with the community advisory board is that they really bring this honest and valuable and practical insights to the project that we would never had, think about it otherwise. So, for example, during our community listening sessions, and we were asking questions to the community, what do you think about this home-based CRC colon cancer screening kit? Do you think it's easy to use? And what about our delivery method of this project? And members address their community's stigma around state government or federal government entities, such as Health and Human Services Department, because we were thinking of collaborating with them and send them mailing the screening kits to our study participants. But after having this conversation, we decided that maybe we would have to design our own mailing envelopes so that it doesn't look like it's from the government entities and it's about something related to them, but it's for cancer screenings. So we designed with the blue ribbons and logos of our screening campaigns. So I think, it also changes the way that we disseminate our findings. So we use different channels that people may have access, such as news articles or social media and community meetings, rather than peer-reviewed journals or academic publications. Recently, we have this beautiful testimonial from one of our study participants sharing her own experience of taking the test, found positive in removing 8 polyps through this project. And she graciously agreed to interview with our team for making a short video clips, and also interview with the news reporter from NBC Today featuring our project. And I just think that this is such a powerful way to disseminate our story, not through the traditional journals or academic articles, but through our community members.
Thank you so much. I really appreciate you talking about just from the advising and the design all the way to the critical component of dissemination, which is coming up in our Q&A box as well. Yeah, Dr. Rollins and Thomas, please share more about your partnership and some of the things that you are all doing in light of this question.
So when I first started in this work, I started with Morehouse School of Medicine's Prevention Research Center's Community Coalition Board. And I'm from the community. I didn't have an academic background. I jumped into the work because my heartbeat was for the work. It's for the people, and felt a lot of times that things that were created from a super high level of theory versus application. And so when I came onto the board, I thought, from the community, I'm going to teach these academics something. And the reality was the structure was already set up for the community to be empowered to be able to direct the research and speak directly into what research projects we were able to attack and which ones we can put behind. An example is our core research project has been on HIV and AIDS for a long time. And one of the ones we had on the shelf that we could attack was diabetes, which now has become our core research project because there's so many things. But some of the ways we challenge the power dynamic is allowing community to have a voice into what happens. We do a community-based survey, and this survey informs our research of what's going on in the community and developing research around what matters to people. The other way of challenging power dynamics in research is the way it's disseminated. A lot of times, the work that's done, the research that's done takes many years to get out and be disseminated and be useful for the CBOs and different people and organizations that can use this information right away. By the time it's disseminated, it's irrelevant at times. If we look at information that was researched 4 years ago compared to now, there's a big change in the way we do things in this country. And so we challenge the partnerships in that everybody at the table is honored. So when we think of CBPR, which is the process we use so much, it's an academic construct. So it comes from academia. And so you have to be very intentional with CBPR to give up power and to allow joint power within the process. Setting the table before the research even begins is highly important. Allowing people who are involved or have experienced the challenge to the table to speak into the process and listen to them. That's important. Giving grace to everybody to grow, because like I said, I came in to this coalition board and I thought I was going to change things because, I'm from the streets. I know everything's going on. And the reality is all of us have experience and everybody has to grow together. And we'll talk a little bit more about partnership, but Dr. Rollins.
Yeah, so I guess, so thank you, Thomas, for giving that context, because it shows that this is a long-term partnership. So yes, we were just funded last year or so for this evidence for action work, but Thomas and I have been working together for about 7 years. And the work, as Fathers Matter ATL, that's been going on for about 3 years. So these are long-term, relationships and partnerships where we're working together to identify challenges as well as, some potential solutions that we can work for together. And so I think his point around, making sure that those fathers with lived experience, they were a part of these conversations. And it was critical for our medical care partners, for our social service partners, our public health partners to hear their voice and hear their experience, for them to be on those bi-weekly calls or bi-monthly calls saying, yes, I got that referral and this is what happened, so that they can hear real time, this isn't what's working. And they were able to put some things in place before we get to a conference presentation, before we get to a webinar, before we get to a journal article, they're able to hear in real time what's happening. And so, we work as a team, and all, as Thomas said, we all bring various skills and strengths to the process and recognize that as such. And flexible, really wanted to make sure that our meetings and things like that were at times where these fathers could be a part, and so, so we've been doing this for a long time, and really embrace this approach to research because, one, it makes it more relevant, it makes it more useful, and also the dissemination of the learnings is more timely.
Thank you so much. I really appreciate that. So this is our final plan question, and then we will switch over into some of the Q&A that are coming our way. But yes, what learnings and recommendations do you have for others who are interested in implementing similar partnerships and interventions, including like what Dr. Rollins said, laying a foundation for many years and building that together, or how Morehouse School of Medicine has really built in a infrastructure for supporting those partnerships? I think that's really wonderful. But yeah, additional learnings and recommendations, both from the project and just kind of the foundations of your partnerships that you have built together.
I would say first you need to find a partner who have the common goal, and have some conversations about what you could do together to achieve that shared goal. Our partnership started from a 30-minute conversation with a strong health advocate for the Black community in Omaha, and who happened to be a Douglas County treasurer. So he's sitting on a few different community health advisory boards because he's just so passionate about helping these community members to be healthier. So we tossed the idea around how to improve cancer screening for the community. And he suggested, how about you give out those screening kits at the DMV and county treasurer's office? So that's how all this started. So that's the first thing. You have to meet the right people who can share the goal. And then I think the second is the trust. Well, if you already have a trusted, established network or partnership with the community, I think that's great. But you may not have that established network or trust. In my case, fortunately, our academic institution, in our College of Public Health at UNMC, has invested in building this community academic relationship through our Center for Reducing Health Disparities. So I was able to meet with Dr. Kiona King, who was a community engaged researcher, had lots and lots of experiences in working with this community already, and who is a resident of the community. So by working with her, I gained trust through her to the community and from the community. And with that trusted relationship, everything went very smoothly. And then the last thing that I like to talk about is, well, I think this might be different for different kinds of partnership, but for my partnership, role clarity was very important. So for each contributing partner's role was very clearly defined, and specific responsibilities were developed together. So we were on the same page of what we need to do for this part of the project. For example, we defined healthcare team's responsibility for navigation services by co-developing our implementation guides that includes work logistics, communication channels and frequencies, letter templates, and phone scripts, et cetera, et cetera. So this helped a lot for our efficient, effective project implementation.
You want me to go first? So when we think about learning recommendations, and for those who are interested, it's always about centering the community voice, being able to understand the community voice. We also talk about make sure you pick right. When we talk about community partners and partners in general, from the community, I need to make sure that I'm selecting the right academic partner, and the academic partner needs to make sure that they're selecting the right community partners. understand that this is for the long term. You know, we have situations where funding comes and funding goes. We have to be able to withstand the non-funding years and the non-supportive years and be creative in ways that we can actively pursue funding and make an impact within the community. One of the things I love about our partnership is we're always looking at not just the research side of things, but how do we implement? You know, we want to go from research to implementation as soon as possible. We want to make sure that we're evaluating the implementation of what we're doing and what are ways we can scale this to allow the community to benefit from it. So when we think about all those steps, we know we need the community's voice as a part of this. We need to really be intentional about the way we're going and understand that the work doesn't stop at the end of the research, that there's still a lot of different ways of engagement. I think one of the things for me and in our organization is if it doesn't make impact, it doesn't make sense. So making sure that you make impact together is one of the main qualities, I think, for our partnership that allows us to continue to grow. So make sure you know what your mission is before you get into a partner so you don't drift away from the initial mission.
Yeah, I'll just add that, it was really important to understand the time it takes to build a partnership. And so, like we talked about, we've been working together for years. But, when you identify a partner, understand it's going to take some time to build that trust, to build that relationship, to see each other's strengths and opportunities for improvement and those types of things. It takes time before you're able to really get into now, all these various decisions you have to make because of whatever funding you have or whatever initiative you're working on together. So we are usually really intentional about having, breaking bread together when we were able to, be in person and those types of things. Just really learning each other as people and, getting to know, each other on a personal level. Because when you can laugh together, you can work better together, all of those types of things. And so it really is about a relationship. It really is about building trustworthiness, not thinking of each other as, that's the academic partner, that's the community partner. Like we really got out of those silos and really, again, held on to those things that held us together, those common goals, that common desire for impact. That's what I think has kept us working together so well over the years.
It doesn't hurt that the three of us that lead this project, our birthdays are July 2nd, July 3rd, July 4th. So, you have to get that kind of synergy going on also.
So in addition to a group birthday party, we're also talking about some other really wonderful recommendations. I love this. You all talked about a couple different things that are coming through the Q&A, and we have a little bit of time. And so I think I'm going to invite the panelists too to kind of go through the Q&A if there's anything that you want to lift up. But as well, I'm going to start us off with, there were two particular themes. One that was about sustainability, which Thomas, you talked a bit about, and kind of how to ensure that the work of your project for the time period that you're funded for a 4-action project, which I think is really important to uplift, that this work that is being, that the funding is coming for impact. It is for action, that there is a direct and immediate outcome for the community, which I love. And also would love to hear more about kind of the sustainability pieces that you have also talked about, and in particular around community ownership of the work that comes through in the projects that you're doing. There was a question on kind of community ownership of data, of story, and of being able to take what is done and translate it into these additional areas of action and impact. So any pieces of that kind of mosaic question. Would love for you to talk about kind of the community sustainability piece and ability to continue on in this work across the partnership.
Sure. I can start a bit. We talked a bit about the sustainability beyond any funding opportunities, continuing to work with the partners, continuing to work with those fathers to make sure we're, staying in touch and keeping the ball rolling, even if the funding is not there. We know there's another opportunity, there's another, chance for us to leverage common resources too. Sometimes it doesn't necessarily take a whole other funding opportunity. There's existing resources within some of our organizations that can be leveraged to do a lot of different things. So we've been able to do that. I'll share, at least for our project, the majority of the funds did go to our community partner. I would say maybe 80% of the grant went to Redemption and Advancement Alliance, to Thomas's organization. So, and all of the data as it relates to that was also with the community partner. And we also had a Google Drive. We use this for a lot of different projects. Google Drives are shared drives where we're sharing the resources, sharing the data, surveys. We're working together on that so that people have access. We're sharing the findings in a way that, hey, if you want to use this survey data, you want to use this tool, you want to use, these findings to advance something you're doing in your organization, you can do that. We also don't really look at advisory boards as advisory. They are governing, they are guiding boards. They do lead the work. They are not giving us just advice for things that we, that was nice, that was cute, but we're going to do this other thing. No, like they have to literally vote and approve our processes moving forward. We provide compensation for all of our members, very well. They are compensated very well for their time to, come to meetings and share their expertise, just as you would expect a PhD or anybody else to come to a meeting and be compensated for their time. So there's no delineation, so to speak, or differences made in the amount of funds that are given to a community member giving their time for a meeting versus a academic partner or a health department partner coming to share their time. So I'll stop there.
The only thing I'll add to that is no one wants to waste their time on a project and just get research and research just goes away. We have some valuable information. When it comes to funding, yes, when the funding goes away, it's a little harder to start to keep the momentum going at the same level. But we do have processes in place that allow us to stay engaged with the same research, with dissemination of or distribution of resources for fathers. Unite Us was one of the big deals that came out of this, which is resources that allow us to continue to receive people within our network and refer them out to other spaces or support them within our own network. And so it's important that we continue the work until the next bit of funding comes around that allows us to take implementation to a higher level. And so we're constantly, before the project was over, looking for ways of funding this. But as we shared before, the data around this group of individuals is limited. And so it's a lot of times we have to we're looking for the right partner that would allow us to do a pilot project and implementation and give us a longer term versus just a year to do, research and implementation. It takes a lot. And so growing this program in the beginning was a challenge. I know there's a question that how many people did we enroll? I think it was 16. And, but that was in a very short period of time also, because a lot of it was the buildup, the research, the understanding, and then finally the action that needed to take place.
Yeah, with this being a pilot, our goal was just to talk to and follow about 10 dads through the process. And we're still, continuing to work with those fathers now.
Thank you both so much. Yeah, JY, if you would like to talk a little bit more on kind of some more of the sustainability pieces. I know you talked a bit about kind of the partnerships with the advocacy partners and even just kind of the follow-up with the sustainability of the community advisory board and other elements throughout your project and afterwards that you're building in. I think, yeah, we've got a couple questions on that. Love to hear in our last few minutes about how you're doing that in your.
Yeah. So yeah, I think we just did our last community advisory group meeting in later September. We actually talked about the sustainability of this project. And I think the community advisory board, we have this strong support from our cancer center that they have the community engagement office who could support our continued meeting with our community advisory board. And then for the cancer screening itself, and the biggest hurdle for sustainability is the cost issue. Because if you would hire a community health worker for kit distribution at those community sites, that would usually requires about like more than 15,000 funding for like 6-month rounds. So we were potentially discussing the two ways. We have all of our training materials, all of our logistics, and all of the implementation guides that we can share with the community. For example, our community cancer advocacy group, Great Plains Cancer Task Force, who's been doing this campaign for many, many years, that we could potentially share all these materials so that they could continue to implement that as one of their community campaigns. The other is we're thinking about using a little bit of technology for continuing our cancer screening. So like, especially for this home-based cancer screening kit, once everything is set up, I think it's pretty self-ordered by the participants. So within that, we were thinking about maybe installing a low-cost kiosk at the community locations, including DMV and churches, and work with our community volunteers and church health ministry to continue to do this round of community screenings through this kiosk. And once people like self-screen themselves for the eligibility and order the kits, then I think we can mail them, and then for the follow-up processes, we could just use the established network. So those are some ideas that we are exploring right now. Yeah, and thank you very much for this question.
Yeah, Jayway, that reminds me that you were talking too about kind of the trainings that you all did with the community health workers, and I'm really curious on how that's been a really prevalent and responsive intervention where communities are able to support their own in this work with the right sorts of training. And I'm curious how on the sustainability piece, like what additional ideas are coming from your community health workers and being able to meet the communities. It sounds like not just the DMV, but faith-based organizations. And yeah, if you could speak a little bit more on the community health worker aspect, because that feels very to one of the questions that came through about not just kind of the advisory, but also the data collection and the enrollment and that piece where the community health workers are supporting that and impacting that. Could you speak a little more on that as well?
Yeah, of course. Our community health workers are really the key people to connect the project team to the community. And they have this unique perspectives about the project. And our community health workers mentioned that, well, you could do this project at the DMB places, but other places potentially like libraries or barber shops and some other community housings that could be potentially good places for this type of work. And for our kiosk ideas, they mentioned that, like, if you think about people 65 and older who may have some limitations in exploring those technology, then, I think you need to really use this technology piece with the assistance of the community health worker, because for some people, human touch is really essential piece of how they could open to this new cancer screening ideas. Actually, our community health workers are so persistent to persuade people. Like usually when they were first asked about cancer screening, they were like, "Oh no, I'm not interested. I'm not doing that." But then our community health workers keep asking that, "Are you sure? Like, when did you get your last checked? Do you know that this is really quick and easy?" So it's community health workers, their presence in those health booths was so critical and important for us.
Thank you so much. There was a specific question for the Systems for Action team to talk more about your experience with the Unite for Us services and care coordination and referral follow-up, and wondering how this system is working for your project and what challenges and successes you have faced using this system.
I think Unite Us has been a game changer, so to speak. Again, we wanted to build something from scratch at the beginning of this pilot project. We didn't get a chance to, and we looked for what was out there, what would allow us to do what we need to do at little to no cost. And Unite Us was really the one that knocked it out of the park, because there's no cost to us as a nonprofit to join. Their staff walked us through the different elements of the database, showed us the strengths, and even identified some of the weaknesses of the database. It wasn't meant for the group of individuals we're working with, but it expanded the amount of resources for this group, and which was phenomenal, because other organizations that we weren't even aware of, we can search for now and find the resources that are needed for the individual fathers. And as we started using it, we started expanding within our network of our fatherhood program to get them into Unite Us. And again, if you're a nonprofit organization, it's free for nonprofits. The referrals are very easy. We receive referrals. If they don't fit our mission or what we're able to do, we just reject them. And but if it goes the same way, we refer out. If they don't have the resources, they'll reject them. But there's communication that takes place. There's a direct person I can talk to. We can communicate over this referral. And so the person doesn't get lost in the shuffle of referrals, and we don't forget, like, we referred this person to somebody and now they're off our plate. No, they're still on our plate, and we're able to follow up. As Dr. Rollins said, we still stay connected with some of the fathers that were enrolled into this process and project.
Yeah, and by nonprofit, that means a 501c3. So, our medical care partners and our public health partners, there is a fee, for them. But luckily, our like Morehouse Healthcare and one of the other healthcare providers, they were already in the Unite Us system. And so it was like, it just made more sense for us to work from that platform to make sure that these fathers were getting the resources that they needed.
Yeah, I really appreciate that question and the answer that you shared, Thomas, just around the strategy of how this unlocks additional resources and that you all are able to utilize that as a tool through your culturally tailored and competent intervention and being able to kind of uh, just facilitate some of that process of the resource accessibility, but also being there to be responsive to the fathers as they navigate those systems. I think what I'm hearing here across both of your projects is just this eye for strategy across these systems, across these different access points, of being able to facilitate that. I guess we have a couple other questions. I don't know if there's any others that the panelists would like to kind of speak directly to in our last little bit of time. I apologize. I thought we were ending at the hour, but we have a little extra, a little baker's dozen of time. So yeah, if there's any other questions that any of the investigators would like to speak on.
I
Yes.
just want to
Sorry, go ahead.
go ahead, JY.
Okay, so I'll go with one question and then you can answer the other questions. So there's this question for the E4A grantee. Do you think your current project focused on CRC screening will open to the door for other public health interventions? My answer is yes, I think it's possible. But I think it's really based on who are your target population for your intervention. As you think of DMV, DMV has two offices. One is the driver's licensing office, and the other is county treasurer's office. The target audience's age is a little bit different for the two offices. Usually, you have more older folks at the county treasurer's office, but you have more younger ones at the driver's licensing office because they need to take the driver's test and getting their ID and stuff like that. So I was thinking that, it's possible to do some other preventions like smoking cessations and other kinds of health promotions in these two different DMV offices based on the target ages and populations.
I was just
Thank you.
gonna
And
comment.
another strategy. Yeah, Thomas, please go ahead.
I'm sorry. I was just gonna comment on strategy. I think a lot of what we're talking about here when it comes to CBPR and how we engage, and when you look at the strategy, you're saying, there's this strategic way of what we're doing. That's because we allow the people who have lived experience to speak directly into the process, and we listen to them and we begin to engage. We come up with theories all the time. We understand that there's needs and we have to meet the need. The best way to meet the need is talk to the person who has the need. And a lot of times we miss that part of our research, and a lot of people do great research, but does it tie right back to solutions? And I think that's the important part about strategy and what we're talking about here is, can we utilize the opportunities we have for research to find solutions that truly impact and make a difference within the people that we serve?
The only other thing I was going to respond to was a question about the advisory boards and like, how do you engage community members in the research processes? And so beyond the committee that we had, we also have those with lived experience who are doing the day-to-day, right? So as I mentioned earlier, most of the funds were given to our community partner, and they went through the city training, which is the institutional review board training, to be able to collect and consent folks to participate in research. So they went through that, got their certification. I worked with them on how to analyze qualitative data. So we went through that and how to interpret it. So, we went through all of those processes, and I don't think that I have any research projects where I am not working with a accountability committee, as well as research assistants or consultants who are working day to day on the research project. So it's not just, we're just meeting quarterly and we're just telling you, and then we're, doing these whole other things. There's always someone with the lived experience involved in the project from beginning to end.
Yeah, that
There
seems to
was
be a really, oh yeah, please go ahead, Thomas.
there's a question, and it's just to add on to what Dr. Rollins was just saying, as far as compensating the community. When we go into the grant, we write that into the grant that they will be compensated at a certain amount. We're very intentional about the time that people spend with us, the value of their time and the efforts that they give. The value that we receive back from for them informing our work is I wish we can pay them more. Just put that. They get paid well, but because they help us with the insight, they give us so much that's necessary and needed. I think, really having a compensation plan for those that you bring to the table, whether it's community, like Dr. Rollins said, the majority of the grant funds went to my organization to distribute to community and other things. And that was good also, because a lot of times, we don't need community getting caught up in red tape to get their compensation. They just need to be compensated. And so we're more agile to do that. And so a lot of times community organizations allow things to flow a lot smoother if you empower them to be able to do that.
That is a similar model that Community Campus Partnerships for Health employ when we are partnering with our institutions to kind of be that bridge between and kind of funnel between the funds for easily accessibility of funds while still maintaining whatever sorts of compliance is needed with the institution, that we can kind of run that interference and be able to make sure that the funds get to the community in a timely and responsive manner. And I also know that that's just another strategy that still we are funneling resources through institutions, but how can we really put those resources back directly to the community? And so I appreciate both of you talking about that strategy as well. We have a few more minutes left. Yeah, please go ahead, Joy.
I think someone was asking about collecting individual data from the community, and I do want to just mention this. This is my biggest lessons learned from this project, that every partnership is different, but for my partnership, we have a partnership with the DMV and healthcare organizations, etc. So most of our partners are governmental or kind of pseudo-governmental that shared some bureaucratic characteristics about this inter-organizational business agreement or data use agreement. And this was a challenge for us when we were trying to get DMV data or transfer our participants' data to and from our health system navigators and with the team. So sometimes this may take over several months, really impeding the progress of the project. So if anybody's planning a multi-sector partnership, it's better to start exploring this process and earlier than later.
That is a very good just thing for people to keep in the foresight of some of these cross-sectoral partnerships. I just want to thank you all so much for sharing your time and your stories and just the work that you all done. And please be sure to check out their projects. We want to give acknowledgements for the Evidence for Action, Policies for Actions, and Systems for Actions, which are, again, national program offices of the Robert Wood Johnson Foundation. If you are interested in seeking funding for your work, these are places to look, in particular for impact and for action. Thank you all so much. We again send our thoughts and just our hearts out to the Policies for Action team. And I hope you all have a wonderful day. Thank you.